you so much for joining us today. We're delighted to have you on our podcast. Your background, your website, your interests are very interesting and very unique. So kind of tell us a little bit about yourself and kind of what transpired to capture this level of interest in women's health.
Sure. And thank you for having me on your podcast. I'm excited. Yeah, I'm a naturopathic doctor, and I graduated about 25 years ago. I've been in full-time clinical practice ever since, helping mostly women with their health and mostly all around issues with menstruation, with perimenopause. I do a little bit with thyroid as well. So I primarily use nutritional strategies, supplements, and a little bit of herbal medicine, sometimes hormone therapy when that's required. And I've written a couple of books, which might be how you found me. So my books are Period Repair Manual and Hormone Repair Manual that have, much to my surprise, actually reached a lot of women throughout the world in many different languages. So that's been really exciting.
I can only imagine. So your background is in naturopathic medicine, and obviously it's a very innovative way to address some of these conditions. Can you tell us a little bit what naturopathic medicine sort of entails or what it means?
Yeah, so, well, in North America, it's a licensed profession. Naturopathic doctors go through similar training in terms of number of years. I mean, it's a different stream of training than medical doctors, but we're trained in sort of all the basic sciences, and then with a focus on using nutritional and herbal medicine strategies.
You know, I've been in practice for well over 20 years. And even back then to advancements today, endometriosis is a really tough disease to treat. So what kind of things do you offer your patients? What successes have you seen over the course of time?
I have been coming at endometriosis. I don't know if you've heard of this before, this might sound, but sort of from the angle of the microbiome and the interaction between the gut microbiome and the pelvic microbiome. And there are some researchers some of them are in Australia, some researchers in Sydney, a microbiology lab there that I actually have some personal connection with, and there's some other researchers in the world looking at the high level of gram-negative bacteria in the pelvic microbiome of women with endometriosis and how inflammatory that is. So it's always going to be in connection with an underlying genetic tendency. There's no doubt that endometriosis has a genetic part to it. And then I think there's an environmental toxin part to it. But I'm more and more convinced through my lens that problems with the microbiome, particularly with the gut, a dysbiosis in the gut, does seem to drive or worsen the condition, which from a natural perspective is a very good starting place, because with changes to diet and using probiotics and herbal medicines, we can reduce the inflammation in the gut, which then turns down the dial, reduces the amount of inflammation entering the pelvis, if that makes sense to you. That's how I approach it. More so with endo, I approach it more from that angle than from a hormonal perspective, because I don't know what your observation is, but a lot of my patients with endometriosis have pretty normal hormones. I mean, they may be having abnormal receptor status or abnormal reactions to their hormones, and endometriosis does produce some of its own estrogen as well, which complicates the picture. But my view of endo, it's not a condition of hormonal imbalance, like, for example, something like PCOS is primarily about hormones.
Yeah, I totally agree with you, Lara. I also think, if you take a condition like interstitial cystitis, that's an inflammatory response of the bladder. It's probably parallel to that of endometriosis. I see patients with IC, interstitial cystitis, also have endometriosis. So there's probably is an underlying common ground there. So I wholeheartedly agree with you with the microbiome. Absolutely.
Yeah. And treating the immune system, you're right. I also have patients with both endo and interstitial cystitis. So just all the different strategies, nutritional strategies for not only treating the gut as a source of inflammation, but also just supporting the immune system to reduce inflammation systemically. That's often, together with surgery and together with physical therapy, that's often a route that some of my patients can try to achieve the magical pain-free status, which is what the goal of everyone with endometriosis is, to get to that point. Yeah.
Yeah, what I would love to see ultimately is women come to some type of a treatment plan early on in the stage of endometriosis. I end up seeing patients, even flying in from New York City, who have like a complete ureteral obstruction because endometriosis has entrapped their ureter. And now, it's a dangerous situation. So that's not the, patient I want to get to that point in time. They need to be treated really earlier on. So I think sending a message out to these folks to say there are treatments, there are ways of controlling this and preventing you from becoming that kind of severity.
Absolutely. And also what we all need, what we're all waiting for, is a non-invasive test, like some biomarkers for endometriosis. So the GPs, the family doctors, can pick it up more like early, as you say, earlier in the process. So you don't have to wait to the point where you need surgical care, where you need a specialist. You could maybe have had some help earlier on as a teen. Like, as you know, a lot of the disease starts in the teenage years, I think, for most women who go down that path. Yeah.
Absolutely.
Yeah.
And I kind of equate it to like cancer. I mean, we've always learned traditionally cancer has like a dual hit hypothesis where you have that genetic predisposition, and then you have some environmental exposure or something that kind of triggers that predisposition to manifest itself. And I think endometriosis IC is very similar to that.
Yeah, I would agree. Yeah.
Yep, it's the evil twin syndrome is what they call it, I believe.
Oh,
They often coexist together, and I think that we see a lot of our IC patients have coexisting endometriosis. So absolutely, in terms of diet and some of these more very holistic approaches. When you talk about diet for these conditions, how do you actually approach that plan for a patient? Every patient's so unique. Even their diet and nutritional requirements and how to support that. How do you even begin to broach that sort of very challenging?
I know. No, it is. Well, it's a good question, because, of course, as you can imagine, I get lots of my readers and followers are always asking me, what is the perfect diet for healthy periods? Everyone wants that. And that's not how it works. It's not how it works, because it all depends on your starting place. It depends on what is going on with you. And then, what are the modifications that you need to have? I mean, I would say broadly, of course, like a whole food diet because mainly a whole food diet is rich in nutrients and feeds the microbiome, and that's a good starting place. I'll just give you three examples, kind of compare and contrast of why it's so different, right? So there's a lot of women out there who have lost their period to undereating, either undereating generally or trying to follow a low carb diet or something, have lost their period. So then if the question is, what is the best diet for them to get their period back? It is to eat way more than they think they need. I mean, there's obviously sort of an epidemic of undereating in certain sectors of a lot of it's driven by social media, I think. So that's something I'm concerned about. I also see in my own patients, and I see a little bit of confusion around the diagnosis PCOS, sometimes being mistakenly given to women with undereating, because it's actually, I'm sure you know, like seeing polycystic ovaries on an ultrasound doesn't mean very much. That can correlate with the hormonal condition PCOS, but it can occur in women with normal hormones. It can occur in women who are undereating. And so as very often in interviews, I like to try to get that piece of information out there. So just like for any of your listeners, if you've been told you have PCOS, it might be, but maybe just think about it a little bit, maybe, read some of the things I've written about that, trying to make sure that's the right diagnosis. Because as you know, the diagnosis for the true classic PCOS is probably to eat less in some form, or to, reduce processed foods, reduce perhaps like desserts and really sugary foods and soft drinks. And that, for that group of people with the true polycystic ovary syndrome condition, they need more of a restrictive diet. So that's example number 2. And then example number 3 would be endometriosis, where it's all about the immune system and the microbiome. They really need a diet that makes their gut healthier, that reduces the chronic bloating or dysbiosis that's happening in their gut. And sometimes for that group, and this is where my naturopathic doctor, part is shining through. But for example, that might be the group with endometriosis where I say you'd probably need to try some time off gluten and dairy, which is not something that I would recommend broadly. Like, I think most women can have gluten, most women can have dairy, but if you've got gut issues and inflammation and that type of inflammation, those foods do seem to be worsening for inflammation, if that makes sense. So that's just sort of 3 examples of where diagnosis is so important. And this is where I encourage all of my readers to, work closely with the doctors to try to get the accurate diagnosis as a starting place, because everything goes from there.
Well, what's interesting is these conditions you're talking about, a lot of women present for many, many years with many different diagnoses that are misdiagnoses before they're accurately diagnosed. So it is challenging for them, challenging for the doctor. But, you talk about the genetic component in these different groups and also just lifestyle, what's going on. We're in Los Angeles. So obviously, your case number 1 is something very familiar to both Dr. Kimball and myself. There is a big movement of like keto diets and being much more driven by, caloric restrictions. So we see a lot of that. With your second population, definitely, I think the PCOS, we know that there are different sort of even categories of PCOS. I know in the Asian populations, actually PCOS presents with a more very, very low BMI, which is a very challenging thing for this population to address. And with endometriosis, I see so many of these inflammatory autoimmune conditions. What's going on at that time of the month could really, really shift what they need. So it's really hard to think, this is what you need all the time. It's just like very delicate balance.
Yeah. And getting the right team, I guess, and getting the right diagnosis. I can't emphasize that enough. It really makes a difference. I feel quite sad about the women under eating, because it's, as you can imagine, it's often tied up with eating disorders, and it can be very challenging to get out of that. And for your listeners, like under eating, losing your period to under eating, hypothalamic amenorrhea is a low estrogen state. It's actually, the low estrogen is very, damaging to bones. It's damaging to the pelvic area, like it's sort of an atrophy. Vaginal dryness, and like that whole picture. That's not healthy for any part of the body. And so we need our estrogen through our reproductive years for not just to feel healthy at the time and for fertility, obviously, but also for our future health. One of the things I talk about, because I'm such a cheerleader for healthy ovulatory natural menstrual cycles where we make both estrogen and progesterone. And again, not just for fertility, but to what I call build metabolic reserve, or I say every menstrual cycle is like a deposit into the bank account of long-term health. Arguably pregnancy would be that too, make a lot of hormones in pregnancy, but every time we get that nice dose of hormones, it's building up our bone health, it's helping our bones and our brain against long-term dementia risks. And this is where menstrual cycles are not separate from the rest of our health. Of course, they're both an expression of our health and a creator of health long-term, arguably.
So a lot of our patients are sort of transitioning into menopause. And we do see a lot of conditions related, for example, to lower hormonal effects right into the pelvis. So vaginal dryness is a common condition. Both Dr. Kimball and I see day to day, at least 50% of our patients we see throughout the day. How do you address something like that using more of a natural approach?
Sure. Right. So this is the whole, like what they call the GSM, or the genital urinary syndrome of menopause. It's not just dryness, as you're saying, it goes beyond that. It's bladder health. It's the structure of the whole pelvis. So to be fair, I'm actually a huge fan of vaginal estrogen. I know that's not, I would say that's naturopathic. That's within the scope of, I just sort of say to my patients, why not use it? Like, especially if you don't, assuming you don't get any side effects from it, like it's there. We have the technology to have that. I just don't, in general, see there's any reason to push through without vaginal estrogen. As you know, like it's, my understanding is it's not a risk, even for women with a risk of breast cancer. The vaginal estrogen is safe, the lower dose estrogen. And I guess in addition to that, though, one of my favorite treatments is zinc. I've just been clinically, and I've seen some research, my observation clinically, and to some extent with myself, I can share that. I'm menopausal now. I've been almost a year since my last period. I just find keeping zinc levels very, replete, or like often with supplementation, or at least eating zinc-rich foods, which is mostly animal products actually, helps with tissue integrity and tissue quality generally. And in my patients who have a good zinc level, even menopausal, a lot of them don't even require vaginal estrogen. So there's something going, that's part of it. I think that's part of being nourished generally. And then the other part of vaginal health at any stage, especially with menopause, is the healthy microbiome, and the vaginal microbiome, which you can maintain by just like obviously not douching or using any kind of chemical wash, letting the vaginal microbiome do its job all the time, recognizing that the vaginal microbiome does change with menopause. So that's the source, I think, of some of the symptoms. So I'm a fan of vaginal probiotics, which they can be taken orally. And the mechanism to that is a little unclear, but they do seem to work orally. I think it's just, yeah. But they can also be taken vaginally. I don't know if you use vaginal probiotics in your practice, but the research is growing for them, which is great.
Right.
Yeah.
I think there is just a handful of studies on the vaginal application of probiotics, which is very promising. But I also I have patients who have, instead of trying to ingest the probiotics, they have creative ways of getting it into that space using methods. So it's definitely an evolving area. Probiotics. What do you think of probiotics in general, not just for the vagina, but you talked about the gut, and then which probiotic do you like or do you recommend as a supplement?
I guess I'll acknowledge it's a rapidly evolving space in terms of research. Like it's even in my latest book, I said the research to probiotics is changing so rapidly. I've really never been able to I don't have, for example, like a favorite product that's good for everyone. I have, as an example, I do prescribe part of the probiotics. Well, it is a probiotic species. It's the Saccharomyces boulardii. Like you can take orally. It's actually a yeast that acts more as an antimicrobial to kind of knock out. It's non-colonizing. Most probiotics they don't colonize, but during the few weeks or month that you're taking them, they can help to, for example, knock out some of the less friendly bacteria that are. The thing about the microbiome, this is my biologist coming through now. There's also viruses, right? Like there's actually some research to suggest that the microbiome, or we would call like the viruses living in our gut, are actually very important in terms of controlling bacterial populations. So that's an example of where I think there's stuff coming, new findings that are really going to transform this. There's lots of different ways to modify both the gut microbiome and the vaginal microbiome. And to be fair, when it comes to the gut microbiome, most of the research suggests that diet is more effective than any probiotic supplement. The gut microbiome is very responsive to diet changes. It really loves, as you know, like fiber, basically plant foods. It needs to eat the whole unprocessed food. That's not. Whenever we eat, we're not just feeding ourselves. We're feeding our gut microbes.
Okay. It's a big way to have neighbors or
exactly. Yeah.
So in our practice, we see a lot of patients with recurrent urinary tract infections.
Yes.
And so part of our education, the algorithm for education and treatment, is to talk about the vaginal microbiome, right? Because the pathogenic bacteria that cause urinary tract infections actually come from vaginal flora, normal vaginal flora. Like you said, the bad bacteria that cause that.
Yeah.
So we need to increase the good bacteria to suppress the bad.
Yeah.
We are a huge proponent of that. So, and vaginal estrogen, we use it on virtually all of our patients. So we support your clinical preference using vaginal estrogen, Lara.
Yeah.
And we applaud you for that.
Yeah. We're all on the same team for vaginal estrogen. The other thing I guess I would prescribe for UTIs is D-mannose. So I'm just curious, do you guys use that at all? Yeah, you do. Yeah. All right. So that's just as you know, it's just a simple sugar that helps to, my understanding is the mechanism, it helps to prevent the adherence of the bad bacteria to the walls. I hope I've got that right. Yeah. It's and it's simple and it's not expensive. And so and actually treating what I give an example actually in my latest book about the importance of getting on top of chronic UTIs, because what happens is if you don't, on the one path, you could have vaginal estrogen or probiotics or D-mannose and change your diet and, have good success. If you go down the track of having chronic antibiotic use, through my lens, that actually has lots of other downstream problems in terms of, for example, metabolism. I sort of work with I think antibiotics are great, and I would never tell a patient not to take them if they need them. But the goal should always be to use fewer, because antibiotics do potentially damage our health in other ways. So we want to keep them in reserve for the times when we really, really need them. Yeah.
Absolutely.
And then eventually you establish this emerging resistance of bacteria to antibiotics in general. So we try to use antibiotics very judiciously.
Yeah, sparingly. Yeah,
sparingly.
For sure. Yeah.
Did you, in your book, you have 2 books, is that right?
Yes. Yeah.
What were the names of your books?
Yeah, I'll just say, so my first one, which came out about 5 years ago, is Period Repair Manual. It's for anyone who has a period or wants a period, of period reproductive age. Sure. And then my second book, Hormone Repair Manual, is for women over 40. It's really about perimenopause. And one of my main messages with that second book is that a lot of the symptoms, particularly the neurological symptoms, is what I'm talking about now, actually occur during perimenopause. So the lead up to the final period. Whereas earlier we were talking about the GSM or the vaginal dryness. That's more of something that comes after the final period. But there's before the final period, there's this time of actually quite high estrogen and high fluctuating estrogen and low progesterone. And it's associated with increased frequency of migraines, heavier periods, as you know. This is a time, I have a quote in my new book from a science writer observing that the 40s are dangerous years for the uterus, because that's the time when a lot of women, especially if they have something called adenomyosis, which is related to endometriosis, a lot of time it's during that decade when women can end up with a hysterectomy. And again, I'm not anti-hysterectomy if that's what has to happen. And I've had patients for whom that was the right decision. But my big goal would be for most women to be able to keep their uterus if they can, because I think, I'd love to hear your thoughts. I think it's actually important for the structure of the pelvis, and it's in there, it's connected by ligaments to other things, right? Ideally you want to keep it if it's possible. Yeah.
Well, you think the bladder's actually physically fused to the cervix and lower uterus. Yeah. So from just a support perspective, it's very important. Now, the one thing I don't like about hysterectomy is the term. It's a horrible term. I can't imagine that it's been allowed over the test of time, that we're removing hysteria. Yeah. It dumbfounds me that we change our nomenclature all the time, right? We change names of things, except for PCOS and except for hysterectomy.
It's true. The two terribly named. I agree with you on both. I agree with both things. PCOS is polycystic ovary is a terrible name, because it's really nothing to do with polycystic ovaries. And you're right. It should have a better name. So yes. So I think, just to say again, one of my little mission statements has been to help women keep their uteruses whenever possible, but also knowing, in my case, clinically, knowing when to give it up. I just had a patient last week who finally did it. She was quite young, and she was only in her late 30s. And it's a bit sad, but also in her case, it had been causing her a lot of pain, a lot of bleeding. And so there can come a time when
it's necessary.
Yes.
Right. Yeah. We're very much on board with that. Our approach is really to look at the conservative measures first, and really patients move towards surgery when we feel like that's the risk and benefit really, really benefit the patient. So,
yeah. So one thing, just on the topic of keeping your uterus, I do, even though I am in general always trying to find non-hormonal birth control strategies, I do in both books talk about potentially the value of the hormonal IUD for some women. I think for keeping their uterus, I guess I feel like if you can, a technology like that exists, I don't know, I'm certainly happy to hear your feedback, but from my perspective, one good thing about the hormonal IUD compared to, say, the pill is that it does allow hormonal cycling. So it does still let you make your own hormones, especially, after the first say 6 months when the dose of the contraceptive drug is a little bit lower. I feel like you get the best of both worlds. Then you get the contraceptive drug to help control the bleeding or the pain, but you still get to cycle. So that's one area where, I've sort of, it's something I try to explain to patients, because what happens, as you can imagine, some women out there have been burned by maybe the pill or certain medical procedures. They're very nervous about any kind of intervention. And so I'm just holding this out to them as just saying, even through a naturopathic lens, there can be a time when the hormonal IUD is, I would argue, better than hysterectomy, depending on the individual, obviously.
Yeah, I think we can always use the hormonal IUD as a first-line therapy for the correct patient. Totally agree with that, Lara.
Yeah.
God, it's been such a delight to have you on our podcast. We had a lovely conversation. We look forward to speaking with you again in the near future.
Yeah. It was a great pleasure to meet you both.
Thank you.
Likewise. Thank you so much for sharing your thoughts and your unique perspectives.